We start with a 62-year-old male who was on peritoneal dialysis for 12 years with no peritonitis. This patient had a transplant end of 2015 and his induction was with ATG and he was maintained on triple immunosuppression. He comes to the clinic after 3 months of transplant with stable renal function with abdominal pain and bloating. This is the CT scan. You can see actually thickened, enhanced and calcified peritoneum and also distended stomach, and plus there is gas under the in the abdominal cavity. So it actually tells you that there is obstruction plus perforation of the bowel. This is the laparotomic view of the peritoneum, and the peritoneal biopsy showed extensive fibrosis with complete replacement of mesothelium. The perforation was located in the fourth part of duodenum, and also this was resected and end-to-end anastomosis was done, and this is the biopsy. So this patient has all the clinical features and the radiological and the histological features of EPS, but this was post-transplant, so this is post-transplant APS. Before this patient had a biopsy of peritoneum during the removal of PD catheter, it was almost normal. So this case has EPS plus the obstruction plus perforation pre-surgery. So technically it was difficult to do the complete enterolysis. So in this case, D4 resection was done with end-to-end anastomosis, plus parenteral nutrition was instituted, and Tacrolimus was stopped, and it was replaced with increasing dose of steroid, and tamoxifen was added. This is the peritonectomy or limited enterolysis, and the patient was left with open wound for 7 days with a biopatch. And after 3 weeks, the patient was discharged, although the surgeon and the patient looks twins, but they are not actually related. So this is actually the actual procedure which was not done in this patient, which is the complete enterolysis. So this can be done, limited procedure can be done in complicated cases, and if you have evidence of both ileal obstruction or intestinal obstruction plus inflammatory changes. And then you have to consider for these patients who are on long-term PD a modulation of immunosuppression. So in these cases, instead of CNI, you can actually choose mTOR. Again, those patients going for transplant for after long-term PD, you can actually consider tamoxifen. But this is also controversial. Thank you.
Thank you. Did you exclude tuberculosis?
Actually, this patient has extensive workup. I only showed the relevant positive finding. He had actually tuberculin test before the transplant, and also the biopsy we did actually both the tuberculin AB staining and also culture. They are all negative actually. And he had actually hemorrhagic ascitic fluid. It was also negative for PCR, for TB, and also for culture.
More questions?